Good afternoon, ladies and gentlemen. Thank you very much for the invitation, especially to Maureen for the invitation and for the organization of this remarkable meeting. My talk should focus on the experience in Europe using radio-labeled somatostatin analog, and that is very challenging. You know, Europe is small. It's definitely smaller than Canada, and it's very patchy. Lot of countries, different opinion, and it's impossible in 35 minutes to summarize the opinion in whole Europe. So I will focus on the best of Europe, and best of Europe is, of course, the center of Europe are the mountains, and mountains mean Switzerland. So I will give you some experience with receptor-targeted radiopeptide therapy in Switzerland. And in Switzerland, Basel is the only place where the therapy is done, so I will speak about the Basel experience. Basel is a small city, 200,000 inhabitants, lying on the northwest corner of Switzerland, very industrial, lying on the river Rhine, and the university hospital you can see here on this picture consists from two large buildings, and I will show later our nuclear medicine ward. But now I would like to start with the topic, with the neuroendocrine tumor, and you have heard a lot of in the morning session and also from my previous speaker. I will go quite faster. The incidence that is very interesting is quite low, 2.5 new patients per 100,000 inhabitants, and the prognosis is quite good. And neuroendocrine tumor are also called slow killer. That means they are growing, but growing quite slow. And what is most important is the sentence which came from the NANETS, North American Neuroendocrine Society: if you don't suspect it, you cannot detect it. And I think it's very important for the physician to remember this sentence. About the neuroendocrine tumor classification, that was a session in the morning. I don't like to repeat everything, but I would like to point 3. The neuroendocrine tumor are usually overexpressing somatostatin receptors, and we are able, using somatostatin analogs, we are able to target the tumor, and we are able to make imaging and also to make a therapy for patients having or suffering from neuroendocrine tumor. You are all aware of the symptoms, and this is again from NANETS, and they have stated any or all of the symptoms could mean carcinoid syndrome, and most of us here will agree that all these symptoms are unspecific. And this is the biggest problem with the diagnosis of neuroendocrine tumor, because we have no clear clinical symptoms how to find the tumor. Only in patient who has malignant carcinoid syndrome, which consists with diarrhea, flushing, and wheezing, only in this patient there are leading symptoms which should lead to the diagnosis. Now to the well, that's again, if you don't suspect it, you cannot detect it. Now to the therapy. As is most diseases, the surgeon has the first what to do, and usually most of the tumor are discovered by surgeon, or if the tumor are discovered by the GPs or by the doctors. The first who see the patient are the surgeon. After the surgery, usually a biotherapy is done using somatostatin analogs, and interferon now is no more fashionable because of the lack of evidence and because of the side effects. And as a third step therapy, we recommend the radiopeptide therapy using somatostatin analogs. There are two which are used, DOTA-TOC and DOTA-TATE, and I will show you later what this abbreviation mean. In patient having a tumor with aggressive behavior with a high Ki-67 index, chemotherapy can be used. You have heard about the chemotherapy before. Now to somatostatin, as mentioned few minutes before. Everybody from us is producing somatostatin. It is a peptide which is produced mainly in the pituitary gland, but also in pancreas. But because of the short half-life time of 3 minutes, it's unsuitable for diagnosis and for therapy. The short form from somatostatin with 8 amino acid is known as octreotide or as sandostatin. It was introduced into the clinic 20 years before and it was synthesized in Sando by Dr. Plesch, and his name is, as you all know, sandostatin. Sandostatin can be octreotide, the 8th amino acid sequence can be labeled, and usually it's labeled with a chelator DTPA, and the commercially available product is indium DTPA octreotide or octroscan, which is used widely worldwide for the diagnosis of neuroendocrine tumor. The DTPA is unsuitable to trap the isotopes very in good fashion, and for this reason we have replaced DTPA. We have replaced DTPA by DOTA, and DOTA is also chelator, but it means that DOTA has a better property to trap radiometals like indium, yttrium or gallium. I will show you later. And we have also replaced phenylalanine by tyrosine, and we have now this compound which is called DOTA-TOC. OC is for octreotide, T for tyrosine, and DOTA means the chelator. And into this molecule we can put gamma emitter if we like to make a diagnosis, or beta emitting radioisotopes for the therapy. And here you can see the X-ray structure just of DOTA, just of the head of this molecule, and you can see in the middle metal. This is our here in the middle is the metal ion, and this metal ion is trapped in this cage. And this is very important, because if let's say 0.5 or 1% of the radioactivity will be free, not trapped into the cage, the patient will suffer from several side effects like aplasia, because metals are trapped in the bone. So it is very important to have a good chemistry and to be sure that your preparation and that the labeling of the labeling of these compounds is more than 99.9%. This is a slide which was also showed before. It's showing the 5 somatostatin subtype receptors, and for TOC, that is tyrosine octreotide, you can see that we have a highest affinity to somatostatin receptor subtype 2, which is found in most of the tumor, and that is the reason why we are using DOTA-TOC and not DOTA-TATE, because we believe that we have a higher affinity to the tumor cells. So our product is a peptide, is a somatostatin analog, TOC. It's linked to the cage, and into the cage we can put isotope, as I told you before, and we are injecting this substance into the patient, and this DOTA-TOC is find his target, which are the somatostatin receptors, and you have seen this morning that the somatostatin receptors are on the cell surface. Everywhere where you can see this staining, brown staining, this is a reaction between the DOTA-TOC and between the receptors which are on the cell surface. So far, so good, but the next step is also very important. This is the step that the whole compound, the receptor target compound, is internalized into the cells, and that it remains in the cells and irradiates the cells from the cell inner space. And here, this is internalization of somatostatin agonist, which is done by immunofluorescence, and you can see for somatostatin 28, which is a normal somatostatin, and for the octreotide, you can see that we have internalization, and that the compound is definitely in the cell's center, and if the substance is radioactive, it is irradiated the cell cells and the cells which are surrounding the cells who has trapped the compound. So, just the next step is the imaging. You have heard about the imaging with using indium octreotide, and I would also like to mention a PET emitter, which is gallium-68, and nowadays we are using for the diagnostic and for the follow-up, we are using gallium-68 DOTA-TOC. The advantage is that we have a higher accumulation in the tumor than by the commercially available octreoscan. These are pictures which you have seen before from my colleague from Montreal, and these are pictures which you can get using gallium DOTA-TOC PET, and everywhere where you have accumulation, everywhere where you have uptake, expect the pituitary gland, spleen, kidney, and gallbladder. All spots are presenting metastasis of a neuroendocrine tumors. So in my experience, gallium DOTA-TOC PET is at the moment the cheapest and best modality how to diagnose and how to find even small metastasis in neuroendocrine tumor. And PET is usually combined with CT, and you can see here a PET image, and it's very difficult to find where the tumor is. And if you combine it with the CT, you can easily recognize when that's a CT, that's a PET, and you can easily recognize that the patient is suffering from a lung metastasis. For therapeutic purposes, we are replacing indium or gallium by beta-emitting radioisotopes, and we have two isotopes. We have 90 yttrium and we have lutetium-177. You have heard in Uppsala and also in Rotterdam, mostly lutetium is used, and we are preferentially using 90 yttrium. The reason why we are using yttrium are a favorable physical half-life time, which is nearly 3 days, and especially much higher energy of yttrium if compared with lutetium. Is 6 times higher energy of the particle by beta decay. So we have a much higher biological activity of yttrium than for lutetium. We have started with the therapy 13 years ago, October 1996, and so far we have treated almost 1,500 patients coming from all over the world to Basel, and we are using DOTATOC. We have never changed our molecule. Here you can see again the university hospital, and this is a view from our therapeutic room. The rooms are not in cellar. Most of the patients are instructed they will be trapped somewhere in a cellar. That is not where we have. Our ward is in the 5th floor, and the patient can overlook the hospital garden. The procedure, we are applying quite a high amount of activity, 100 millicurie per square meter body surface per treatment cycle. And because using yttrium, the patient has to come usually only twice. You have heard if you are treating the patient with lutetium, you have to apply it at least 6 or 8 cycles, which is much more convenient for the patient to come and have the treatment using yttrium. And we are, of course, as all group, performing a kidney protection, giving the patient an amino acid infusion. The only problem with the therapy is available only in Basel. We are not allowed to sell DOTATOC to other places. We have allowance to do it as an in-house preparation. That means the patient has to come to us. It's not possible to transfer it abroad. I would like to show you some pictures which has been done from a patient coming from Canada. He came from Vancouver to us. He's a professional photographer, and if you go into the exposition in next door, you will find a picture from him from the Yosemite Park, and I advise you to buy the picture because he's firstly a nice man, and secondly he's an excellent photographer, and he made the first photography in Toronto during his trip to Basel, and this is a photography by landing in Zurich, and he has developed a special kind of photography. He explained me how he makes the picture. I didn't understand it, but I have included a picture showing you the center of Basel, and we are still old-fashioned and having such a old tramways running through Basel. But some places are quite nice, like this city wall. And this is again done by him during his stay in our room overlooking the garden. And on the second day, when the therapy has been done, is a picture from the garden to the hospital. And this is our ward, as I told you, in 5th floor. And we have eight possibility to treat 8 patients every week. And after the therapy, if the therapy is well tolerated, the patient can go out and visit the surrounding of Basel, cross the River Rhine on this old-fashioned ship, or walk over the bridge. And even if they stay a little longer, they can visit a museum or go to the famous Basel Zoo. Well, and then on day 3 or 4, they can go home, and this is a picture from Zurich Airport, leaving home to Toronto. Now I will come to the part which probably most of you are interested in, and these are our results. We are dividing our results in two big groups. The one group is the improving of life quality, and we are evaluating our patient, and we have seen that especially in patients having malignant carcinoid syndrome and suffering from diarrhea, flushes, and asthma, most of these patients are improving after 2 cycles of DOTA-TOC therapy. And the second improvement of life quality is, of course, in patients having pain being coming from bone metastasis or from liver involvement with the tension of the capsule. Most of the patients, you can see more than 70% are reducing their painkiller, or even they can stop the painkiller. And the second group are the cytoreduction. That means how is the tumor response, how is the tumor reacting to our therapy, and we have seen, like most of the groups in Europe who are performing the therapy, in few patients, roughly 5 till 10%, we have a complete remission. It's mostly unusual. We have partial remission in about 15 to 20% of the patient, and we have a stabilization of progressive disease in most of our patients. And there are still about 15 to 20% of the patients who are progressive despite the therapy, and I will show you later why this is. Now, one of the positive results, a patient having a liver involvement, a lot of metastasis before the treatment, and then after the treatment, you can clearly see that most of the metastasis has disappeared. And I would like to present you one case, a 20-old years lady who was diagnosed 1 year before having a well-differentiated endocrine tumor from pancreas. She was treated in France, in Paris, by chemotherapy. I don't understand why, but she was treated as first and second line chemotherapy, and then because of a progressive disease, she came to Basel, and you can see her primary tumor here, and you can also see a big accumulation in the spleen, in the thyroid, and in the muscle behind her eyes, and also an accumulation in a brain. And her thyroid function was completely normal. She also got a biopsy from the thyroid, and that was a tumor. And when she came to us in August, she got a therapy with yttrium, and a day after the therapy, we can confirm all the metastasis. Here, the metastasis in meningia, then metastasis in muscle, in the eye, thyroid, tumor, and some metastasis in the ribs. And 2 months later, during the second therapy, all the metastasis disappeared. And you can see here CT and CT SPECT once more showing the accumulation in the orbital muscle before the therapy, and that the orbital muscle metastases were cured by just one course of DOTA-TOC therapy. So the tumor response, according to the WHO criteria, are showing positive response in roughly 80 to 85%, and we have about 15 to 20% of patients who are not responding, who are showing progressive disease despite the therapy. We are now about to evaluate the survival time in all 400 patients, and so far we have evaluated 632 patients concerning the survival time, and we have seen that in the first 600 patients, we have reached a survival time of 62 months, which is roughly doubled of the so-called historic control, doubled the time which was achieved before DOTATOC therapy was introduced. So it's quite a good result. We have also evaluated that are the old patient, and we are also evaluating the patient by disease. And I would like to show you just two examples. One are patient having paraganglioma and pheochromocytoma, and we have evaluated 28 patients, and you can see here a patient suffering from a huge paraganglioma, which was couldn't be operated. And here are the results. In paraganglioma, you can see again 70% of the patients are responding well to the therapy. And the time to progression, this is another important parameter to analyze a therapy. It's the time to progression was longer than 17 months, and the longest duration was 45 months. And another entity are patients having gastrinoma, and in patients having gastrinoma, we recommend as follow-up not only the scintigraphy and CT, but also the estimation of gastrin as a tumor marker. And you can see here a young patient. He was 23 years old when he presented with this tumor. That was in July 2003, and he was treated with 2 cycles of DOTATOC, and 6 years later, he's still tumor-free, and his gastrin level is in normal value. So gastrinoma are also tumors which are responding very well to DOTATOC therapy, and as a follow-up, we recommend the regular estimation of gastrin. What are the parameters which patient will give a good answer or good response to our therapy? What are the predictive factors? The predictive factors are definitely the uptake in the tumor and the uptake in the metastasis, and we are making a graduation. And grade 1 is a uptake in the tumor which is less than the uptake in healthy liver. Grade 2 is uptake which is comparable to the healthy liver, and grade 3 and 4 are uptake which are definitely higher than the liver, or even higher than the uptake in the kidney. And if you compare this patient, then we have a very good results, therapeutic results in patient having grade 4, a high uptake. We have quite a fair or good results in patient with grade 3, and we have a moderate results with in patient having a low uptake in the tumor. And in most center, patient having a grade 1 or 2, most of these patients are not treated or are not included in the DOTATOC therapy. And we have performed 2 studies looking whether we can or we should treat this patient. And I would like to show you briefly the results of this studies. And these studies are on patients with dedifferentiated thyroid cancer which have been previously treated by iodine 131, and this tumor have been no more responding to the therapy. And we have evaluated the patient the response has been evaluated by estimation of thyroglobulin. Thyroglobulin is tumor marker, and after first therapy, we have looked whether the patient having a response to thyroglobulin, whether the patient had a response to thyroglobulin or not. And we have seen that despite a very, very low uptake, 1/3 of the patients are showing a decrease in thyroglobulin, and the further statistic analysis has shown that patient responding, that means with a decrease of thyroglobulin, they have a longer survival time, 42 months, in comparing with 13 months in patients who didn't respond. And very similar data was obtained in a patient having progressive medullary thyroid cancer, again 31 patients, and as a success parameter was the response to calcitonin. We have measured the calcitonin before the therapy and after the therapy, and we have seen that despite a low uptake, every third patient has a calcitonin decrease, and again, this patient have show a better survival or longer survival time than patient without calcitonin response. So my opinion is that even if you have a patient with a low uptake, it is worth to send it to the treatment, and after the treatment to look using a tumor marker whether the patient are responder or non-responder. And the second parameter in patient having no tumor marker, we are measuring the efficacy of our therapy by estimating the uptake background ratio and by measuring the diameter on CT. These are SPECT CT from a patient who have shown a decrease of the uptake background ratio by 32% and a decrease of the diameter by 40% between the first and second therapy. So we are monitoring the patient. During the therapy. Now the last word are the 15% who are not responding, and the reason for non-responding are lying in the biology of the tumor. Here on this panel, you can see a tumor which is a very, very homogeneous distribution of somatostatin receptor, and here on the right-hand side, you can see a tumor with a very inhomogeneous distribution of the tumor. Here, this part of tumor are expressing somatostatin receptors. This part of the tumor is not expressing somatostatin receptors. And if we treat the patient, this patient will have a very good response, and this patient will have only a partial response because this part will respond, but this part will grow further. And it is very important to have the histology before, but only in a few cases of our patient came to us with the histological examination. So we are now performing both octreotide scintigraphy, and we are also performing FDG scintigraphy during the hospital stay. And make the story short, if we find a patient with a high FDG uptake, we know that this patient will have a poor prognosis, and we recommend that this patient should be treated not only by DOTATOC, but this patient should be also treated with chemotherapy to improve the survival time. One word to the side effects. Every therapy which is effective has also side effects. This is a SPECT CT showing the accumulation of DOTATOC, and you can see the accumulation is in spleen, and the accumulation is in the tubuli of the kidney. So we have to expect a lymphopenia, which will persist in most of the patients, and we have to also expect a kidney problem, and we have evaluated, or we are evaluated the kidney function by measuring of creatinine and we have seen that most of the patients are having an increase in creatinine value after the therapy, but usually the creatinine level remain within the normal level. The normal level in hospital is 120 millimole. So I have started with the mountain, and I will finish with the mountain, and I am coming to the conclusion. Our experience is that about 80 to 85% of the patients are well responding to the DOTATOC therapy. We have a progress-free interval up to 6 years, and tumors which are suitable are the tumor with high somatostatin receptor expression, but also tumor having a low somatostatin receptor expression, as medullary thyroid carcinoma, kind of thyroid carcinoma, and thymoma should be treated. The indication, the tumor should be progressive. We are taking in our therapy only patient having progressive neuroendocrine tumor or suffering from carcinoid syndrome or tumor-associated pain. The condition, the tumor must have somatostatin receptors, and the blood counts and kidney function should be more or less normal. And with these slides from Grindelwald, I would like to thank you for your attention.